My name is Pepijn van Voort. I am a cardiologist, electrophysiologist in the Cath Hospital in Eindhoven in the south of the Netherlands. I'm doing EP for 20 years now. Well, so we started 20 years ago with PV isolation and doing more and more procedures, and I think we did all the techniques available at these times. And we switched to FARAPULSE 2 years ago, and we had a steady increase of procedures, number of procedures, and that the increase is still going on. Well, the patient experience, we are performing the procedures under deep sedation, so patient is sleeping during the procedure, and after the procedure he awakes and he doesn't feel any pain anymore. Just waiting for the leg, for the groin. That's taking some time for the patient, but patients are very satisfied. Yeah, well, the heart suite, it's a kind of short stay ward. So patients come early in the morning or later during the day. They come around 2 hours before the start of the procedure. They're prepared by the nurses, and we are taking the patients from this short stay ward to the EP lab by ourselves. And after the ablation, so after 1 hour, we send patient back to the ward. They remain there for several hours and after on average 6 hours they leave the ward, and so they are going home the same day. Yeah, well, in the lab we're working with one doctor, with 2 or 3 nurses slash technicians, and 1 sedation nurse. In general, we prefer to have 3 nurses. It's a little bit easier for the workflow. So, and the patient is entering the EP room. He's being sedated by the sedation nurse. We do the procedure, and afterwards he's sent back to the ward. Well, after removal of the sheets, we always have 6 hours waiting time. So patients who are back in the ward too late, so after 4 o'clock in the afternoon, often these patients remain the night in the hospital. But all the other patients that are going home the same day. So there's no special workflow is needed. It's just sending the patient home. And well, and explain the patients and explain the nurses that it's safe to send them home the same day. After several hours, after 6 hours of observation. Well, before we started FARAPULSE, we did cryoablation. Also, cryoablation is very efficient already. So we did 5 cryo procedures per day. Now we're doing 5 or 6 FARAPULSEs per day. So FARAPULSE is a little bit faster, a little bit shorter procedure than cryo. But when we started cryo, many patients were referred to us. So we were the second center in the Netherlands. So many patients were referred. So the waiting list actually increased instead of going down because of the short procedure time. But we're doing more patients now. Yeah. Also during cryoablation, we already had deep sedation, also performed by a sedation nurse. And sedation is even more important, deep sedation or general anesthesia, even more important with FARAPULSE. But we didn't change the approach, the anesthetic approach. So patients were deep under sedation already before. But it's really require that patient is very deep. That's really necessary. Yeah, that's very important. And I know some colleagues are still doing sedation themselves with midazolam or propofol, but so we have a dedicated sedation nurse, and they're really very experienced, so they're doing sedation every day or almost every day. And over the years we've seen them gaining more experience. So they're now very experienced. They use propofol, they use midazolam, sometimes they use ketamine and morphine, and we really have excellent sedation with these patients. So we have this dedicated sedation nurse, and he is responsible for the sedation. And he, in case of trouble, he can call the anesthesiologist, but that's very rare that that's necessary. So he's responsible for the sedation, also for the hemodynamics. During deep sedation, patients always have low blood pressure, so noradrenaline, phenylephrine often is necessary for the blood pressure. So they administer propofol, midazolam, ketamine and morphine to get a deep sedation. Well, deep sedation can be difficult in some patients, particularly in very obese patients. They can have problems with respiration, and sometimes it can be difficult to get such a deep sedation that the patient is really deep asleep, and then he stops breathing. So sometimes it's difficult, so we had a few cases and we had to change the sedation to general anesthesia, but it's very rare. Yeah, it's important to make good to discuss this with your anesthesiologist, to have a good team, and you can ask the anesthesiologist to perform every procedure on the general anesthesia, but it's more easy for them, more convenient to have these sedation nurses. But these nurses have to be supervised, have to be trained, have to get experience in sedation. It takes some time. So for the workflow, the patient is coming to the hospital around 2 hours before start of procedure. He comes to this short stay ward, the heart lounge as we call it. He gets some questions by nurses. He's prepared by the nurses, and then he's put in a bed. And at the start of the procedure, we are going to get the patient from the heart lounge. That's a 1 minute walk, and we take the patients by ourselves to the EP lab. And then the patient is put on the table, and the anesthesia starts with the sedation. Now that takes 5 minutes, and then the patient is asleep. In the meantime, we are preparing the procedure, and then we start the procedure. When we start, always the patient is deep under sedation. We do the procedure, and at the end of the procedure, we remove the sheets, and the sedation is stopped. And after 15 minutes, patient is taken back to the ward. And patient remains about 6 hours there for observation, and after 6 hours he's sent home the same day. Unless it's late in the evening or in the night, then he remains for 1 night in the hospital.